Hi everyone. Very nice to meet you. To see you guys. We are just after Labor Day weekend. Hopefully you guys all had a really wonderful weekend. I'm just putting the go live on Instagram, and I'm all ready for you. Today, a really cool question, and I never thought of doing any lives on it. And it was a question on, can you do something about biologics? And I'm so excited to talk about this today. And if you don't know me, I'm Dr. Isabelle Amigues. I'm a rheumatologist, direct care concierge practice in Denver, Colorado. And I've done rheumatology both in France and in the US at Columbia University because I really, really love rheumatology. And today I have a piece of paper, kind of, because hopefully I'm going to be able to explain to you what a biologic is and how we're thinking when we're thinking of treatment in rheumatology conditions. So a little case before we start. So very often, so it's not even a case, it's just like common, okay? And as you may know, I'm very much someone who likes to bring Western medicine because it's so powerful, right? We have so many medications, and the biologics are some of the newest medication who have really changed the face of medicine. So we have Western medicine. And then I really like to add Eastern medicine principle because they empower our patients. So think of it as medication. Western medicine is something that the physicians like me, offer to you to rebalance your system. And you have the Eastern medicine principles such as meditation, cold plunges, healing therapy, healing sounds, and so on, qigong movement, etc. All of this is to empower you because you have the ability to do it on your own. And you're not going to see your rheumatologist every week. You may do qigong several times a week. So really, that's what we are saying when we're saying we're combining the two, because why choose one or the other when you can have both, right? And so very often I'll see patients who come to me and they have, I'm going to just take an example of a patient with rheumatoid arthritis. So rheumatoid arthritis comes in with, so a patient comes in with rheumatoid arthritis, severe joint pain, swelling, several hours of morning stiffness, and they've already tried some other medications, methotrexate, sulfasalazine. They are like usually pills, right? And so we know that the goal in rheumatoid arthritis, and honestly, big scoop here, the goal in every single rheumatologic disease is actually remission, which is different than cure. Remember, remission is just no sign, no evidence of any sort of sign of disease, but you do have with a medication, right? Whereas cure would be you have no sign of disease and you don't need a medication anymore, okay? But I think remission is pretty damn great because you don't realize that you have your condition except when you're taking the medicine. So, right, so rheumatoid arthritis, they come in, they have, and they still have joint pain, they still have swelling despite being on methotrexate, for example. We know that we need to achieve remission. So our second step after putting methotrexate, that's usually the first line, is to add a biologic or a small molecule, okay? And usually we put that biologic and patients get into remission. Sometimes, and actually it's not rare, that the biologic is not enough. After 3 months overall, we use, 3 months. Sometimes we can do it a little bit earlier if there has been zero response or very little. We switch to another biologic, and we switch like this every 3 months until we have full remission. Our goal is full remission. The trick to target, the target in that case is full remission, okay? So I'm just going to give some very good studies, some very good cases. The truth is that the vast majority of patients will reach remission with biologics. The reason I became a rheumatologist is that when I started doing medicine, in France, I think in the US it had started a little bit earlier to use biologics, but in France we were finally starting to use biologics. And so, for example, so we had the mentors that taught me rheumatology at a very early stage of my career, right? I think I was like 18 or something. they would actually take care of patients with rheumatologic disorder inpatient, meaning that they were hospitalized and they needed steroids, they needed like IV infusion and so on. And then the biologics came, and the first one was a TNF inhibitor, Remicade or infliximab. We'll talk about that. And that basically changed the way we practice rheumatology. And although I did start going to hospital and taking care of patients who were hospitalized, they don't need any more inpatient or very little inpatient. So in hospital care, because the vast majority, if not almost every single rheumatology patient can be taken care outpatient. And the reason for this is that the biologic came in, okay? So there's a reason why I became a rheumatologist, is that we can get patients to remission, and it feels really, really good to do that. And when I came to the US and I had the choice to choose another specialty, there was no way I was going to choose any other specialty, because this specialty is the best. You put patients in remission, so how good does it feel? All right. So now we're going to talk about biologics. I don't know for you, but I feel like I always never have a piece of paper. So it's usually my mail that comes in and is being used. But you're going to see. I mean, I'm going to try to explain it, and hopefully you can understand how we are thinking. Okay. So if we're thinking of our immune system, there's two types of immune system, systems. All right. We have the B cell and we have the T cell. The B cell are, so basically lymphocytes, right? That's what's in our lymph, when we're saying my lymph nodes and in our lymph. That is what makes a lot of the immune cells, okay? This is what helps you to recognize what shouldn't be in you, whether it's an infection or just a bacteria, or something that should not be here. Or we make cancer cell all of the time, because our body is really good, but it's not perfect. But we have so many checkpoint lists, right? And so our immune system recognizes that there's a cancer cell problem, for example, we'll get rid of it. So our immune system is really incredible. And the goal of our immune system is to keep us in balance so that we can live in the environment we live in, right? And so we have two types of immune cells. So I'm going to try to do this, but just bear with me. So at the top is just, lymphocyte. And then we're going to say there's two types, right? There is the B cell, and then there's the T cell. I swear this is not complex. If I can understand, all my patients understand it, okay? So we have the B cell, the B cell, and then we have the T cell. The B cells are going to make immunoglobulin or antibodies, okay? So, when we're getting a vaccine, we are basically stimulating our B cell to make antibodies, all right? So we're basically you're basically teaching your body, hey, look, you may be in contact with this pathogen, right? So virus or bacteria. We want you to recognize it early enough so that the moment you see it, we want you to target it and take care of it. Okay. So that is the immunoglobulin. It takes a little bit of time to make an immunoglobulin, okay, or an antibody. So this is not the system that's going to be the fastest one, but it is very sophisticated. I love that word. Okay. So our B cell is a very sophisticated cells. And then we have the T cell. The T cell, see them as this is very, very fast. And it basically, it's going to be like pro-inflammatory protein. Basically, you have, so let's say, you're eating, every time we eat, we have a little bit of bacteria that are going through our guts. That's absolutely normal, right? That's why if you were to take your temperature after eating, you would see that the temperature rises a little bit, okay? Well, our T cells are making those pro-inflammatory cytokines. So I'm going to call them because you're going to see it's important. So among some of the cytokines it makes IL-1, IL-6, and TNF. Okay, scoop. IL just means interleukin, the first one that was found. Interleukin 6, 6-1. I don't know if it's a 6-1 was found, but I'm sure it's that. And TNF just means tumor necrosis factor, because it was found when there is patients with cancer, they have very high TNF, and it's so the tumor. I believe it was found for in cancer patients, and they were seeing that they were there to take care of the tumor, right? But we all have that, and we need it. Again, it's a question of balance. We need it in balance in our body, right? So that's a little bit more active. It's not active, but fast. It really comes fast. And the B cell, I'm going to say this, we said sophisticated as the word, and this is very efficient. So let's say B is very sophisticated and T is very efficient. But the truth is that everything is very efficient and they work together anyway, right? If the B cell is, so another way that I explain this, I say, well, the B cell is more, the B cell system and immunoglobulin or antibodies is more of a diplomatic way, right? So you have spies, and then you have like diplomats that are making sure that all the things that are inside of you are doing great, and so on. And then the T cell is more like the soldiers, and then you have little soldiers going on and just taking care of things, right? Well, so in the past, when we were making medicine, we either started from how do you call that? From plants, right? Really, like if you think about it, plants or fungal or bacteria, right? Like penicillin is nothing else than sorry, but basically it's literally, I think it's a fungus. I'm so sorry if I've done an infectious disease, but I haven't explained this for a while, but it's nothing else than something that came, that's living basically. And we created the penicillin, but so it's like a living thing. And the plants also, like digitalis is a plant, and that's how we made digoxin, which is still used today for patients with arrhythmia, right? So that was in the past what type of medicine. We still have them, but that's how they were created before. And then the biologics came. And the biologics are really what has changed the face of medicine in the last 30 years, right? Because basically, super cool scientists have created medications that target directly some of those cells. So for example, for B cells, so to get rid of B cell, we have something called rituximab, and we have many biosimilars now because it's been for 30 years it's been there, right? And what it does is that it actually goes into the receptors. There's a little receptor on all of our cells, by the way. There's a little receptors that's specific to the B cell called CD20, all right? And we have this drug that's going to basically target the CD20 and flop all of the cells that have a CD20. And so because of that, you'll have less immunoglobulin or less antibody. And so, for example, for patients who have ANCA vasculitis, which is inflammation of the vessel that can be very dangerous, cause fever, like skin rashes, joint pain, a lot of inflammation. If you get rid of the B cell, you get rid not of all the B cell, but you get rid of the vast majority. And what happens is that you have less immunoglobulin, you have less antibody. Among those are the bad antibody, the one that are causing problem. And so then you go into remission. So that's cool, right? Like you basically have this one drug that goes directly where the problem is. So that's for vasculitis. Or there's a cancer that causes B cell overproliferation. You may have heard of lymphoma. Well, lymphoma can respond super, super well to Rituxan, which is the CD20 inhibitor. And again, that is actually how we found that Rituxan could work for our patients with rheumatoid arthritis. This story for another time because I'm seeing the time, okay? But it's really cool, actually. The story of Rituxan in patients with rheumatoid arthritis is a very cool story. Ask me if you want to hear that story, I will. Okay. And then we have those other biologics. So we have biologics that are going to take care. So I talked about the TNF, right? TNF inhibitor. They're going to basically stop anything that is related that's TNF, and they can do this different way. They can either block the TNF that's soluble, like such as etanercept or Ambrel, or they can go directly to the cell and say, no, now I'm going instead of the TNF into your receptor. Sorry, I'm like imagining that I'm a little molecule going into the receptor on my head and basically saying, now you cannot stimulate me because I've already taken your place, right? So you cannot stimulate me, okay? And so because of that, you have less inflammation, and that's one of the problems in rheumatoid arthritis or other sort of rheumatologic disorder. And you have less of this, and so this is actually super efficient. Humira, things like that, right? Humira, Ambrel, Remicade work really, really well. Then we have the IL-6, so tocilizumab, Kevzara. You probably have heard of those if you have giant cell arteritis, or if you may have heard even of this in patients with severe COVID, because it works for patients with severe COVID. And then IL-1 is an anakinra, same thing. It takes care of the IL-1, takes care of the IL-6. In general, we don't put them together. Sometimes you have to, but that's very specific case, very rarely. So in general, we don't put them together, different biologics. Then we have biologics that basically block the communication between T cells and B cells, or B cells and T cells. That same thing, just like a little receptor tells us exactly where it is. That's really what a biologic is, right? A biologic is nothing else than something that has been made to be very specific to a very target of the cells, all right? And then we have what we call small molecules that are not considered necessarily biologics. I think we can put them all, but basically the small molecules would be like, if you've heard of Rinvoq, of Xeljanz for rheumatoid arthritis, for example, they are basically taking care of some of those JAK kinase inhibitor that are same thing. It's just a cascade of inflammation. Okay. Okay. I think I talked really fast. Maybe I was very excited to teach you this. I don't know. Hopefully this is all good. But overall, if I go back, what is a biologic? It's just a very targeted treatment to take care of a rheumatologic condition, but actually not just rheumatologic condition. It actually takes care of cancer. And it's really just seeing it as something that's much more targeted. If I take my little piece of paper here, what you have to realize is that prednisone is like a nuclear bomb that gets rid of all. It's not at all specific. Methotrexate gets rid more, it gets rid of everything, but it's because it decreases the proliferation of the cell. So it's absolutely not as targeted. And if you ask around people who have rheumatoid arthritis, for example, or other rheumatologic condition, you will see that once they are put on a biologic, they usually have much, like if it's just a biologic we're talking about, they don't have really a lot of side effects from it. What side effects can you have from a biologic from this? When you think about this, it's basically you may have a risk of increased infection or increase of the severity of the infection. And why is that? Because you're decreasing the response of your body to infection or so on, right? But if you really think about it, it's like you're just reestablishing the balance. So what I mean by that is that this is anyway not in balance when you have rheumatoid arthritis or when you have an inflammatory rheumatologic condition and you're trying to put it in balance. So overall, what I would say is I'm going to be very personal. The reason I became a rheumatologist is literally because TNF inhibitor, so the first biologic in rheumatology, the TNF inhibitor, started to be on the market and were starting to be given by my patients. And I will always remember this patient who had horrible psoriatic arthritis, and she was bedridden, and suddenly she gets those drugs and she's able to get out of the hospital. She's able to have a fully normal life, to exercise. And she actually told us that she had been able to make babies, so have to become a mom because she was finally in full, I don't think she was in full remission per the standard of today, but at the time she was considered like close to remission, basically. And when you're a medical student, like, it's just like the most wonderful feeling to see someone have their lives changed because of a medication. I mean, I don't think it's because of me as a rheumatologist that my patients are doing well. I really think it's just that we have so many biologics are as tools in our toolbox, and I think that that's what's really wonderful, and it keeps getting better and better. Okay, 20 minutes. I'm really behind. So sorry about that. But hopefully you enjoyed this. If you're watching the replay, this as a replay, please put it as a replay and then hashtag replay. And then don't hesitate to ask questions. I see a bunch of you. So Lady Lucas live, thank you for joining. 2202, thanks for joining. Omar, me here, Frisco Petit Mom, hi. And then Heather, hi Heather. And then Rock Dog. Such a pleasure to see you always. And I'll be here next week. Thank you so much, Heather, for saying you are amazing. And thank you for Rock Dog for always enjoying the lives. Such a pleasure to be here always. And yes, I think that biologics are wonderful. Have a wonderful day and wonderful week. I will see you next week. Take care, everyone. Bye-bye.